And then number 19, if something new happens, does your child look at your face to see how you feel about it? So again, remember with that earlier when I was saying, if you turn your head towards something and they're looking at your face, sometimes they're looking at your face to figure out whether or not they should be scared, they should be excited, and that's a normal neurotypical response. And majority of the time, a failure on this is when kids just don't seem interested. So you could be jumping up and down and doing jumping jacks, and they just don't know why you're really doing that, and so they don't share that. They don't look towards your emotional reactions and try to read you. So that's part of their pragmatic language skills delays. They're not able to read you. They're not able to decode those nonverbal cues. And so, and one of the interesting parts of that RITA test is that they're actually looking to see if kids know what to do when a parent is fake crying or when a parent has a flat affect. So these kiddos just have a really hard time decoding that. And so they may not look at you, or they may look at you, but not know what to do with your response because they can't read that facial expression. So this one's not going to usually come up as a false positive. It's just not one that I've seen come up much. And then, does your child like movement activities? So do they like to bounce and swing, and do they get excited when you do things to swing them around and stuff like that? Do they ask for more, when you're swinging them between your arms, or they're going on a swing? And if they don't seem to want to enjoy that, sometimes the movement is just an issue for them because that may be sensory overload for them. Sometimes they just don't want to. It's just not fun for them. It's not as exciting as spinning the wheels on the car. So like I said earlier, the MChat with the follow-up questionnaire is available online, and it's a good one to print out if you're not used to using the follow-up questionnaire. So you can have it available and run through it until you kind of get used to doing some of these things and it becomes second nature. And then this is the scoring program they have, if you wanted to do that, but it's pretty straightforward, 2, 5, 12, and then the rest are supposed to be yeses. So, and then I wrote it again in here, just to review everything that we talked about earlier. So 2, 5, 12 should be a no. The rest of them should be a yes. 1 to 3 failures, they are at risk, but low risk. Greater than 3 failures are at high risk. And again, doing the follow-up questionnaires for any fails and considering sometimes as a fail, and getting more information on it. So this is, and maybe it's not attached to this slide. Oh, there it is. This is a CSBS that I was mentioning to you guys that you may have done if you guys were involved in that SARC study way back then. And it's a good checklist, and I'm not going to go into detail on it, but it's an interesting one that they can do as early as 12 months. Obviously, the earlier we screen them, the earlier we get a diagnosis, the earlier they can get help. And we know that the MCHAT doesn't start till 18 months and really isn't as accurate as it is at 24 months. This is more promising for the younger kiddos. So, and it's really looking at the difference between their social communication of a neurotypical child versus a child on the spectrum at 12 months. And those are things that you can see. Once you get used to seeing these kiddos, you'll see kids who are 6 months old and they clearly have autism. They don't have great eye contact. They're sitting there flopping when they're excited. They're not smiling back at you, but they're smiling at some object, So there are some things. So it is nice, but it's hard to see those things if you're not the parent, and it's hard to see those things if you're not an experienced parent. So right now, I think they're still working on the whether or not that'll be more of a standard tool to do for the younger kiddos. So currently, all we really do for the screening is the MCHAT. And then, well, we said about half of them actually end up having autism and half of them have something else. And so you really want to know what they have and whether or not it is autism, again, because if we go back to the beginning, we were talking about the negative impact of the false positives. You are going to increase parent anxiety, the cost, decrease the availability of clinicians to be able to do the evaluations on the kids that actually need it. So these are level 2 screeners, and the STAT is something that you, I think, are going to be learning in this course. And that one is the one you can do in the office and schedule them, and you can do it. Technically, you can start as early as 14 months, but it's typically for the 2-year-old. It's typically for the 2 to 3-year-old, and then they have scoring that's for kids less than 2 and kids above 3 before they turn 4. And it's a good tool. It doesn't pick up as much as the higher functioning kiddos. And those kiddos actually struggle to get diagnosed early, but it is really good at picking up the majority of the kiddos and the kiddos that are just going to be more severe. So the other one is the RITA. It's the RITA T for the toddlers. rapid interactive screening test for autism in toddlers. Actually, Dr. Fry just sent me the information on this a few months ago, and I learned how to do it and have used it on a few patients, and it's great. And I think if you guys get the opportunity to learn this, it would be great to use, because you can do this in less than 10 minutes. And it really helps if you have a kiddo who has a positive MCHAT and you just want to know whether or not they have it, and give the parents a peace of mind one way or the other. If there's an extreme, if your RETA score is extremely high or extremely low, it kind of helps you guys. The SORF, which is the systematic observation for red flags, it's not going to be done in our offices. It's something that's probably more psychologist, SARC, or research based. So the STAT is a completely separate visit. I'm never able to do it on the same day. I have to set them up for it. It says it's estimated to be 20 minutes. I find it to be more like, it just depends on the child. It can be up to 30 to 40 minutes. There's 12 items. A score of 2 at the age between 2 and 3 is considered a high risk. They recommend that the parent isn't present, which is difficult for some kids because they can't part from their parent. And then if the parent is present, you have to have them be quiet and act like they're a fly on the wall, basically. And then the sensitivity is good, 0.92. The specificity is 0.85. So much better than obviously the MCHAT, and it gives you a lot better ground to stand on to give your families sort of guidance for the next step. And then we talked about the preferred age, and then there's a significant amount of training required to do it. The RETA is the one that I said is a pretty quick one. Parents are going to be there. You're actually asking the parents to participate in some of this. And so far the studies are showing sensitivity of 1. Like, I don't even know if that's really ever heard of in any study, but it's there in the literature. And then the specificity of 0.84. And so if you have a kiddo who has a score of 18, you can just tell them pretty quickly, okay, we really look like we're talking about autism here. So let's move on and get things going so that we can get a diagnosis. We can get treatment as early as possible. Whereas if you have a kiddo that's got a score of 4, you're not going to be chasing this as much unless there's some other things that are standing out, glaring at you. You're not going to put them on a higher priority to get diagnosed and all that other stuff. So, but again, I don't know if you guys are going to be doing the RETA in this year's EAC. I think it's just sort of something for you to know about. There's a lot of different tools that are out there that you'll see as you start going through all of this, that the schools do, that psychologists do, all that other stuff. So we're done sort of talking about the screening tools. I wanted to go over some of the potential barriers from a realistic primary care physician standpoint. So reimbursement for the pediatrician. So reimbursement for the MCHAT is pretty good. The STAT, you can get reimbursed based on the time that you spent, and the RETA is kind of nice because it's just like a clinic visit. It doesn't take that long, so it's easier to get the reimbursement for it as part of a clinic visit. We don't have time. We don't have time in the day to see that kiddo and then follow up on a lot of these things. So it's really learning these things ahead of time. Just to, right, Dr. Fry is telling me something. Just to clarify that, the RETA training is next month. Awesome, cool. So it's, and then a lack of familiarity with the tools. I think the STAT was a lot harder to learn than the RETA, but it may have been my level of experience with autism by that point. And again, there's so many other things that are out there that you find that other providers have done, and then you have to review them, and it just becomes a lot more complex. And then of course, if you have this 18-month well visit, parents think there's nothing going on, and all of a sudden the MCHAT is like, wow, glaring positive. It's going to take some time to talk to them, and you can't let it go. And so it's going to disrupt your flow. And the bigger barriers are referrals. And so that's why we're all doing this, right? We want to learn how to be able to diagnose ourselves so that we can help the families get early diagnosis and not get stuck in the 6 to 12 month waiting list for a developmental pediatrician, and then 6-month waiting list to get into ABA, or 6 months to get DD. All those things end up delaying the time where our patients can get their help. So, and then parent and clinician belief system. So there's a lot of fear with the diagnosis. So parents don't necessarily want to hear it. So it takes a little bit. And that I found has been the biggest barrier in my being able to diagnose kids. I'll have kids come in, they do all these things. I tell them it's very likely they have autism, follow back up once you've gotten the speech therapy evaluation, and they don't. And then a year later, they're like, well, I think maybe he does have autism. Or divorced parents, one of them believes it, one of them doesn't. So that's been a huge delay for diagnosis. And then of course there's some clinicians that, don't believe that it's there. I don't think there's a lot, but there may be some clinicians that don't believe that it's really, truly as prevalent as it is. The prematurity thing I thought was interesting because I've wondered about many of these kiddos that I have that were early and what this has done to their brain development, and the rate of autism in the community, and the rate of premature babies that are still continuing to thrive, and even extreme preemies. Some of them are doing great, talking, walking, eating by themselves, but they're, that cognitive development and the social emotional connect and all of that is a bit of a higher level that's going to take a little bit more help. And luckily these kids usually get into those NICU programs and all of that, so they're getting early help, but you just have to kind of keep it in the back of your mind that that's something that's out there that you'll have to address. So it still can be elevated in kids in 29 to 37 weeks. So even, a 36 weeker who's considered borderline is still at an elevated risk. Obviously, kids who have severe issues, so they said the oscillator and intracranial hemorrhage, in less than 34 weeks are at higher risk. The longer they stayed in the NICU, the lower their birth weight. And then the studies vary, but they're showing 3.65 to 12.9% prevalence in these kiddos versus the 1 to 1.5% in the general population. So there's definitely at least a twofold increase with the premature babies. Some of the studies they did showed a statistically significant difference in kids who were twins that had simply 100-gram difference in their birth weight. So the nice thing about this is that they are more likely to outgrow it. So they've done studies and they've said there's early intervention and really getting them what they need. These neural pathways can be developed and they are more likely to have a better outcome than kids who have a genetic predisposition for it. So, and then they have noticed that they have more of the DSM-A. So the DSM-A is all the social communication, the social emotional reciprocity. Then the DSM-B, which is those restrictive repetitive behaviors, sensitivity, noise, flapping, spinning in circles, and all that other stuff. I don't know why I wrote screening tools MCHAT versus CSBS. Maybe because the CSBS is going to be more early on. It's going to pick up some of these things. And that's it. Look at that. I don't know how long I've been going because there's no clock on this thing, but these are the questions. I really don't know if you guys want me to go over the answers or if you're supposed to go over the answers. I'll wait for Dr. Fry to tell me what I'm supposed to do with them. But this is your quiz. The MCHAT-R is a valid screening for toddlers between what age and what age? 12 to 24 months, 6 to 24 months, 16 to 30 months. I feel like you guys are supposed to be able to answer this. So I'm not going to say anything unless he said everyone is supposed to do these independently online. Okay. And that was right. Somebody who responded. Oh no, you're not supposed to respond to everyone. Don't answer it. And then what's the first step in patient scores between 3 and 7 on the MCHAT-R? You guys can read it on your own because you're supposed to do them independently and I don't want to give everybody the answer. And then MCHAT-R revised with follow-up is considered diagnostic of autism. So I hope I didn't go too fast for you guys. I'm got that New York in me. Sometimes I forget to slow down. Okay, perfect. You guys are going to go to the web link and fill out the final survey that will allow you to get CME credits. Anybody have any questions that you can just send me on the group chat? We can unmute too if you want. I don't know if that's helpful or not. I unmuted everyone. So if you're on and you have a question, ask. If you're done, have a beautiful evening.
Does anybody have any questions? A lot of information.
Yeah. Sorry if it was a little bit of overload. All right. Then
Super. Well, let us know or email us if you have any questions or if you have trouble with the links or anything.
All right. I think everybody's checking out. They're all saying thanks.
All right. Go see the debate.
All right. Sounds good. Do we want to?
Probably
all right.
not.
Thank you. Mm-hmm.